of the Priya. He is a lecturer at the Faculty of Medicine, Tirana Medical University, and he is the head of the teaching unit Service of Endocrinology and Metabolic Disease and University Hospital Center, that is named as Mother Teresa. He is the president of Albanian Diabetes Association. He graduated from the Faculty of Medicine, Tirana, Albania in 1992, and from thereafter he was a resident and diploma of internal medicine till 97, and afterward he was a resident and diploma in endocrine and diabetes, and he speaks and writes fluently in English, French, Italian, received the title of Doctor in Medical Sciences in 2005 with the thesis Prevalence of Diabetes and its Chronic Complication in Metabolic Control and Diabetes Treatment in Tirana district. He is a associate professor in 2010 and professor of medicine thereafter in Tirana Medical College in 2015. He is participant on several national and international programs of diabetes, such as Albidiab, screening diabetes retinopathy 15 years after St. Vincent Image Project, and he is also invited for delivering a lecture at ESD postgraduate course and national representative of IWGDF. He is the initiator and the moderator of different training programs for PWD, GP, nurses, and pharmacists in Albania. He is the first author of writing group of national guidelines on type 2 diabetes in Albania in 2008 and 2012. And during this period, from 1997 to 2015, has published as the first author or co-author more than 13 articles in peer-reviewed journals, and he has presented more than 50 oral presentations in national and international conferences and Congress on Diabetes. So the floor is to Dr. Florian Toti, who is going to speak about the new insulin therapy, safer, longer, and faster. Dr. Toti, please. Dr. Toti, you are mute, so you have to unmute your mic.
Hello.
That's it.
Thank you. Hello, everybody, and thank you for inviting me to this marvelous congress. That it is normal now. That is virtual. It's very interesting this session, especially, and I wanted to add some data about the new insulins. Can you see the slides?
Yes, yes.
Okay. So we are all familiar with how insulin is secreted in people without diabetes and what is the problem, especially with type 2 diabetes. More clearly shown in this graphic when we can see that especially for the oral glucose, people with diabetes tend to have a later answer. That's why the postprandial glucose is much higher to people with diabetes, and impaired fasting glucose is the first problem of prediabetes. This is the people that are known in the world for discovering and using insulin for treating diabetes since 1921. Very soon we will have 100 years of insulin use for people with diabetes. And this is Marjorie, a less known dog, who was the first dog with diabetes made by pancreatectomy. And Leonard Thompson, the first person treated with insulin. Since then, more than 100 million people have been treated with insulin, and we are all very familiar with the miracle of insulin, with changes in small children already dying, of diabetes, and they are living today thanks to insulin. But after the discovering of insulin, we were known with chronic complication of diabetes. Some of them are more familiar to us, some of them are less familiar, especially gastropathy and peripheral vascular disease. But we have to remind that when the people with diabetes are diagnosed, they have lost about 50% of their beta cell function, and their insulin resistance is more than 40% present in them. And diabetes is very costly due to its complication. If we reduce the glycated hemoglobin, we can reduce by 60 to 70% the complication of diabetes. If we reduce by 1% the glycated hemoglobin, we can reduce by 37% the microvascular complication, diabetic nephropathy and retinopathy. We can reduce by 43% the risk for amputation. We can reduce by 21% the death related to diabetes, 14% the heart attacks, and 12% stroke. And some of the messages that are very clear from the large studies made with type 1 and type 2 diabetes was that be aggressive with glucose control in type 1 and type 2 diabetes at diabetes onset or shortly after to prevent long-term complication, to have a glycated hemoglobin of less than 7%, and primarily in young middle-aged subjects free of vascular complication. But what we are facing today, we are facing a failure due to clinical inertia to our patient. In these slides, you can see that when the insulin therapy is initiated, the average patient has accumulated 5 years of glycated hemoglobin of more than 8% and 10 years of glycated hemoglobin of more than 7%. And it's true that specialist care endocrinologists are adding insulin faster, but even in this case, they are neglecting to increase the dose or to make a combination of 2 or more medicaments in people with diabetes. And when the general practitioner were asked when they would start insulin, if they were diabetics, they will start their insulin for their own at 8.2% of glycated hemoglobin, but actually they recommend the insulin to their patients when the glycated hemoglobin is about 9.6. So the insulin therapy is initiated much later with a heavy risk for having diabetes chronic complication. And we know that higher is glycated hemoglobin, more important is the role of fasting glycemia. And when the glycated hemoglobin is about 8.5 to 9.2, the role of postprandial and fasting glycemia is almost the same. And the earlier basal insulin initiation can give a bigger low of glycated hemoglobin. If we can see, if we start the insulin when the patient are with a glycated hemoglobin of less than 8%, it's true that they don't lower too much the glycated hemoglobin, but 75% of them will attain the goal of glycated hemoglobin of less than 7%. Why? When the glycated hemoglobin, the insulin is initiated when the glycated hemoglobin is 9.5, it's true that they can have a bigger decrease in glycated hemoglobin, but only 33% of them will achieve the goal of glycated hemoglobin of less than 7%. This is how the insulin is produced by our pancreas with bolus when we have the meals, and the basal insulin during the night or during the fasting period. That's why we have the rapid-acting insulins and the basal insulin. The first rapid-acting analogs are Lispro, where there are changes in amino acid lysine and proline, and Aspart, and the less known is glulisine. But how do they are their pharmacodynamics is different? We can see that the insulin aspart is faster, for example, than human insulin. But faster insulin aspart is even faster than insulin aspart in itself. That's why they are used as pre-meals. We can see in this graphic what is the difference between insulin aspart and regular insulin, and we can see that insulin aspart, as all analogs, are with a higher and faster pharmacodynamics compared to regular insulin. And Lispro and Aspart have almost the same profile as we can see in these slides, where almost all the values are similar to each other. While the faster insulin aspart, even more faster than aspart in itself, and we can see that they initiate, that it starts earlier the effect, and after 30 minutes has already the double of the effect to lower the glycemic level compared to insulin aspart. From 15 to 30 minutes, the action of the faster insulin aspart is much higher than the insulin aspart in itself. And this is true for the subcutaneous injection and for the insulin pump use. So we can use the faster insulin aspart even in the pump. In the study onset one, the estimated glycated hemoglobin change from baseline was more significant with faster insulin aspart compared to aspart in itself, or even to the aspart before the meal. As for the safety findings, the number of adverse effects was similar between insulin aspart and faster aspart post meal or in the meal time for at 26 weeks and 42 weeks. Insulin 200 Lispro is a new insulin Lispro, more concentrated and with a similar action of insulin compared to Lispro, but much faster than rapid insulin. It has the same dose as 100 units insulin Lispro, but half the volume. We need to monitor the potassium level. Would have fluid retention, especially when it is used in concomitant with TZDs. And the most common adverse events are hypoglycemia, allergic reactions, injection site reaction, lipodystrophy, and pruritus, which are almost similar with all other insulin. So, for the basal bolus treatment, we have the bolus, which are analogs, fast-acting analogs or faster-acting analogs, and the basal insulin. The basal analog insulin, the more known are glargine 100, detamine, which are the first basal analogs, and after that we have some biosimilars, as it is abasaglar, which is a similar of insulin glargine of Lantus, and we can see that they have almost the same pharmacodynamics between them. So no changes in studies made with abasaglar compared to insulin glargine. And we can use them as basal analogs especially to cover during the night or during the fasting period. Insulin degludec, it's a new basal insulin it's produced in hexamers, and after that they are linked together to create a long multi-hexamer assemble, and after that they are deposited in subcutaneous depot, and the zinc diffuses slowly, causing individual hexamer to disassemble, releasing monomers. That's why the pharmacodynamic of insulin degludec is much flatter and much longer than the other insulin analogs, even in studies where you can inject it during different hours in different days, always having insulin in circulation even after 24 hours, but without any risk of hypoglycemic. This is the day-to-day variability between degludec compared to insulin glargine 100 units and insulin glargine 300 units. You have seen it in the previous presentation from Professor Lalic. And we have now combination of insulin degludec together with insulin aspart, so we can have 1 or twice daily injection instead of 4 injections per day. Another basal insulin is insulin lispro-pegylation. With the pegylated chains, we can longer the effect of insulin and having a much flatter pharmacodynamic. The most fearsome problem for insulin treatment is hypoglycemia, and which has a considerable burden to patient and society. In studies made in UK, Sweden, and Germany, we can see that the cost, direct cost related to hypoglycemia, is from 39 to more than 40 million euro per year for treating and preventing hypoglycemia for people with diabetes. That's why one of the most important tool to compare the new basal analogs to the old one, or especially to the NPH, is the risk for hypoglycemia, because they are all very efficacious to lower the glycated hemoglobin, so they have a better metabolic control. They have less weight gain with new basal analogs, but what is more important is that they have less risk for nocturnal hypoglycemia. For example, comparing insulin glargine 300 units compared to insulin glargine 100 units. And the same, it's true when we compare degludec, for example, with glargine 100 units. Another study was the CONCLUDE, a trial comparing the efficacy and the safety of insulin degludec and insulin glargine 300 units in people with type 2 diabetes inadequately controlled with basal insulin and oral antidiabetic therapy. And they have compared diabetic patients treated with insulin glargine 300 compared to insulin degludec 200 units. And the post-hoc analysis showed lower glycated hemoglobin and fasting plasma glucose for the group treated with insulin degludec, and less weight gain for people who treated with glargine 300. Lower dose were used for degludec 200 units compared to glargine 300 units, and there were no differences in hypoglycemia during the titration period, and no difference in the overall safety profile. But the severe hypoglycemic events in the group of degludec was much lower. And now we have a new basal insulin, once weekly insulin icodec, the new insulin from Novo Nordisk, and we had some studies. The last one was published just in November 2020. When they concluded that estimated mean change from baseline and the glycated hemoglobin level was 0.33 for the group treated with insulin icodec once weekly compared to the glargine group, and the rates of hypoglycemia with severity of level 2 and 3 were lower in the group treated with insulin icodec compared to glargine 100. Another issue with the new basal insulin is a so-called risk for some kinds of cancer due to the high level of IGF-1 receptor affinity, especially for insulin glargine. But in the study origin, we didn't see any increase in cancer incidence with basal insulin compared to the human insulin. Just 2 words about the insulin exubera, inhaled insulin, which can be used as a bolus insulin. This is the comparison of the pharmacodynamics of inhaled insulin compared to the regular insulin, and we can see that the inhaled insulin has a much faster action compared to the regular insulin. There are some limitations to use it. It is used only in adults and in type 1 diabetes, but together with basal insulin, not for diabetic ketoacidosis, and we need to assess the lung function prior and during treatment. So, as conclusion, we need to remember that we need to titrate insulin to keep glycated hemoglobin of less than 7%, titrate basal insulin to fasting blood glucose between 100 and 110, 5.5 to 6.5 millimoles, titrate prandial insulin to 2 hours post-meal of less than 160 or less than 9 millimoles, and in summary, insulin therapy replaces complete lack of insulin in type 1 diabetes, supplements progressive deficiency in type 2 diabetes. Basal insulin added to oral agent can be used to start therapy. Full repriasis requires a basal bolus regimen, and hypoglycemia and weight gain are the main medical risks. But the new insulin analogs and injection devices facilitate use. In type 2 diabetes, use insulin according to the rule of 5 amps. More in more patients, more early at diagnosis or shortly after, more physiologically, prefer basal insulin first and prandial later as needed, more aggressively, treat to target, and what is more important, more safely, minimize the risk of hypoglycemia. And we need to remember that the insulin is a natural hormone created by nature, not by drug companies. But it is what exactly is missing in people with diabetes. If we can make a diagram of where we are, we began in 121 with insulin and syringes. Now we are here, and we are very close to the closed loop, as Professor Lalic mentioned in his presentation. And the future can have microneedle patch, which can give like a small robotic insulin in the needed dose at the needed moments for people with diabetes. But still, we need the education to know how to treat and how to improve the glycemic control to avoid lipodystrophia, for example, in people with diabetes, and to have some jokes even about diabetes. And with that, I wanted to conclude my presentation and to thank you for inviting me to this wonderful congress. Thank you very much.